I think we'll make a start now. So the apologies for absence are Chris Clayton, CEX Derby and Derbyshire, ICB, Gino Di Stemfer, University Hospital.
Do you want me to read?
Yeah, you can do it.
Hiya. Apologies from Councillor Lismore, Councillor Dooley, Councillor Redfern, Michelle Arrowsmith, Stephen Bateman with Sabiu Hussain to cover, Avia Bhartia, Penny Blackwell, Gino Di Stefano, Lee Sherrow to cover, Duncan Gooch, Helen Henderson Spores, Aaron Johnson, Chris Paneer with Kate Pugh to cover, Andy Smith, Drew Smith, Simon Stevens with Lisa Holford to cover, Sean Thornton, Sue-Ann Lim, Christine is here, sorry, she might be late, James Moore from Health Watch, Kim Harper and Jane Needham, and that's all. Are there any more?
I have Paul Hazelgrave, Councillor Hazelgrave as well.
Thank you.
Right, we have no late items, so any declarations of interest? No. Right, so we shall move on. Confirm the minutes of ICP meeting. Can we confirm the minutes of the ICP meeting on 18th of June?
I've just got one small correction, if I may, on page 3. Underneath the 3 items around the key areas of focus, start well, stay well, and age and eye well, the paragraph underneath, it mentions that following the presentation by the Director of Place and Partnerships provided an overview of the strategy, the Vice Chair of the ICB highlighted, and actually it was either the Vice Chair of the ICP, because it was Kathy, or it was the Chair of the ICB highlighted. So we've kind of mixed our terminology very slightly. So I think it should probably be the Chair of the ICB raised. It's a minor point, but Kathy is Chair of the ICB or Vice Chair of the ICP.
Is it noted?
Is that okay?
Yeah, that's noted, Jim.
I think that was you, Kathy, wasn't it? I think it was, yeah. You are the Vice Chair of the ICP, but you're right. Thank you, Jim. Thank you for pointing that out. So it should... Sorry.
It's all right, go for it.
Sorry, I'm just remembering. Sorry, I was
No, you're
chairing,
okay.
so
No, go
sorry,
on.
taking over there.
Go
So
on.
it's Chair of the ICP, isn't it? Thank you.
Yeah.
Sorry.
No, that's fine. So are we ready to confirm the minutes now? Yeah? Right. Are you going to propose and I'll second?
Yep, I'll propose them.
I'll second. Okay, thank you. Right, the next on the agenda is 5, update on the integration between Derbyshire Community Health Services and Derby City Council. Community First annual report. Jim?
Thank you very much. So I thought we'd start, if we may, with a 4-minute video, which very kindly our technical team has set up ready to go.
Tend to support people to prevent hospital admission, and we also promote independence and return to independence when they come out of hospital. It's been quite an interesting journey for all of us because it's bringing together what we already did as 2 separate teams, the Home First team, which was Derby City Council, and DCHS Rapid Response. So it's building those 2 teams and bringing them together. And it's been a real change in culture within our service to think about strengths-based assessments and how we put that person at the centre of our care in a social care way as well as a health way. So thinking about the next steps, we're bringing the 2 services together on Pathway 1, which is people in their own homes coming out of hospital. So that's a big lot of work that we're doing on the digital integration, so using a shared care record, documenting on System 1, which we're hoping will go ahead for the 1st of October. And also it's really nice in that respect that we're bringing in the social care element as well. The social workers have access to System 1 and then they will be able to document on the same system and see that documentation so we can have a really nice joined up care as well.
I think social work does add value to community health services. I think we bring a different perspective, whereas our health colleagues predominantly focus on the person's health needs and recovery. I think we look at the bigger picture. We focus on that person's social needs, their economic needs, housing. We look at their culture. We try to overcome barriers that prevent people accessing resources. We work to safeguard those customers. We make sure that people have equitable access to resources. So together with our health partners, we work holistically with the person and their family to improve their health outcomes and improve their well-being and their quality of life. Our experience of moving into DCHS has been very positive. We felt very valued. We've had visits from the executive team to meet with my team. I think DCHS have made great efforts as well to actually find out what it is that we do, because social work is one of those roles that is actually a little bit of an unknown quantity. The staff team found the transfer with talking about salaries and terms and conditions, that was seamless. My team are making really good use of training opportunities. 3 members of the team are already enrolled or have completed management courses, and we're now in the very early stages of looking at a social work apprentice route. The Hospital to Homes team primary focus is always to reduce length of stay, both within the acute hospital and within all pathways. We are assisting with the implementation of community transfer hubs. We are working with our Community First partners to improve the Pathway 1 offer, and we are now really starting to embed and look at how we can enhance our role with admission avoidance and the front door.
So just a short video from some of the people involved in the changes, and the report that's attached to the documents today is the annual report, and some of the City Council colleagues and health colleagues will have seen this before because it was presented a couple of months ago, but we agreed to bring it to this Integrated Care Partnership because it is a different way of working between health and local authority and social care. What the report goes into is some of the aims that we were looking to achieve in the first year. We look into how we've successfully actually dealt with the challenges around Pathway 1, which is looking after people's homes when they come out of hospital, and Pathway 2, when we take them through a bedded facility, in this case Perth House. I'm pleased to report, and the report demonstrates that the access standards were good and maintained above target. There was an area of pressure with our Pathway 2 bedded care facility where we had to do some repair work, which meant a reduced number of beds for a period of time, but we've maintained flow. And that you'll see there's a financial element in there as well, which talks through how we have met the need within the resources available. And in fact, there's been a small surplus that's been carried forward into work for this year. You'll have heard there some of the staff impacts, which have been generally good, and clearly in a big transformation and change, that could be an area of real contention, but was well seen by both sides, and it does feel like a bit of a DCHS NHS sales pitch. I appreciate the video. It was used for another purpose, but I thought it was useful to see here. Most importantly, the resident feedback, the service user feedback, is also very, very positive. There have been 2 complaints across the period of time, which, given the number of contacts we have, I would say is remarkable, but we have paid close attention to that, and the feedback is generally positive, but there are areas for improvement, and I think at the end of the first year, that feels like a good foundation for us to work from. There's a look forward in the paper to what are we trying to do this year. We're linking in with the Community Transformation Programme, and I'm going to hand over to Andy Appleyard in a second to do the slightly contrary view, not contrary view, the complementary view of where we are with that. And just to report that the Care Transfer Hub work that was just mentioned in the video and the digital work has gone live on the 1st of October and is working pretty well, actually. I've seen a report this morning showing the visibility we now have on resource across the whole partnership that allows us to be more effective in getting the assistance that residents need more quickly. So I was just going to hand over to Andy Appleyard, who's sort of my counterpart on the City Council, and then we'll open back to you for any questions, I think. So Andy.
Thanks, Jim. So hi everybody, my name is Andy Appleyard. I'm the Director of Adult Social Care at Derby City Council. I don't think there's a significant amount that I can add compared to what's already been said. I think this was a really ambitious programme for us, trying to look at how we can follow up on the work that was already happening. We are very keen to try and put people at the centre of everything that we do, and their experiences are paramount no matter which type of service they receive. So building on some of the things that Jim has talked about, there's been a significant number of people that have gone through this process and a really small amount of negative feedback. I think it's quite clear that it's delivering on the outcomes for local people, which is always what we intended to do at the outset of this. I think probably the biggest endorsement that we can give this from Derby City Council is our inclusion in the Community Transformation Programme, which will build on the work that has already happened. As I say, it's a very ambitious piece of work, but now starting to work with wider colleagues across our system. So I'm sitting here with Lisa today. I'm not going to ask Lisa to speak, but I think there's been that wider recognition across the system about what this has actually delivered, and then other people are trying to be involved and copy some of that good work. If we find a way of delivering better outcomes for people, we don't need to reset the wheel. So, as I say, for year one, I think we're very happy with where we are, but this is certainly the first step on a longer journey of how we continue to collaborate, work together and deliver better outcomes for local people.
Excellent. I mean, the report is absolutely fantastic. I mean, the few complaints you've got really are negative, really, compared to what's happening. You know, any questions from anybody about the report? No? No? Go on, Alison.
Just a comment, if I may, please,
Yeah,
Chair. Yeah, I think it's, and thank you for bringing this report here today. I think it was important to share it. I know that this body itself is in a bit of a flux, and we're going to talk about that later on. But it is important. We've had so much discussion about integration in the last few years since I've been involved in this, and this is one of the concrete projects of integration. And I know the Community Transformation Programme, which I look forward to getting an update on sometime, is that as well. So just to say, it seemed an extremely positive project. Really what the system has been tasked to do, really, and it seems to embody that. So it's really good. And of course, the most important thing is that get better outcomes for people. And it's good that you've got positive feedback from the people using the service. Thank you. Thank you.
Kathy?
Yeah, thank you, Jim and Andy, for bringing the paper. A comment, and then if I can ask for a question of clarification on some aspect of it I don't quite understand. But I think one of the real positives here is this working between health and social care, this seamless coming together. I recently visited out in Buxton a team that was working, and they were literally in a room together. And I asked people there whether or not they were all employed by different people. They said yes. I said, but do you feel like a team? And they said yes. So I think it's this sort of working together that brings real benefits. And we can see that writ large, actually, through the video and through the paper. So great, and it's actually not been going that long, has it? So, you know, what do you expect, really? So there's one question I have about the ambition. Where does this hope to go? What could it do? And my clarity question is, can you just explain Table 1, really, the Pathway 1, compared to 24-25, compared to 23-24? What would you have hoped to see? And is this it? Or what there's a sort of explainer in the narrative that sort of dismisses it, really, but I just wonder if it matters. Thank you.
Thanks, Kathy. And let's go straight to, I'm going to turn my back to you so I can be looking into the microphone, sorry. Let me go straight to the Table 1 question, if I may, around the slight decrease in referrals. So yes, there is an ambition there around ensuring that in the first year, 80% of referrals were met and demand was met within resources. we got to a much higher number than that. The reporting is relatively immature, and I can see Chris Fine at the back there. There is something here around statistical process control chart plotting of demand versus the way that we attend to it, because we saw a 2-month variation in demand that may or may not have been something significant. We have an ambition to get to 95% of the demand being met within the timescales. That is a building picture. And depending on how you cut it, we get there straight away. We know that the demand profile from the feeder end in the NHS is growing year on year on year. And so we are trying to, within the resources we've got, contain that demand safely and effectively for residents. So I think I am not worried about that small deviation of a 2.7 decrease across the year profile. In year one, as we come through that, that feels not a material difference. We will track it through control charts to make sure that we are attending to any change in behaviour. And I think it's difficult not to look at you, but where we have the team working together, what we're beginning to see now, literally this month, is the ability to plot resource, and that is where wastage has happened before, where we have had a resident attended to health partners and social care partners at the same time without knowing that each other were going. That gives us an opportunity to meet the future demand, the increase in demand, because we can share the workload better than we've been able to before. So visibility of the work allows us to more properly address our resource allocation. And that's, I suppose, coming back to the finance point, that's why the finance point is so interesting. We've managed to work within the resources available and have some spare. That means that as demand increases, we shouldn't necessarily need more resource to attend to. We can use our resource better. Finally then, community transformation programme is around improving that again. So there's a kind of continuous learning environment we need to get into, because the demand, ageing population, the acuity of people who are living longer with more disease burden means that these services are essential, and we'll either have to grow these services, which is difficult in the financial constraint, or make better use of them, and that's what this programme is trying to do. Does that answer, Kathy?
Yeah, I suppose if I may just come back, the only one was just that sense of ambition. Where are we really hoping to get with this?
And I think that might be the session we're going to get to next, which is, so we have a health and social care strategy across the footprint that we're looking after. At the last meeting, we confirmed that the direction of travel was the right one. I think it's for this body, or whatever follows it, to set the ambition, and then it's for us as officers to execute. How do we, with the resources we've got, deliver that?
Andy, it's all right, I can see you, Dave.
Not a problem. So if I could just add a little bit to that, if that's okay, Chair. I think certainly from an adult social care point of view, one of the things that we haven't been very good at, and probably epitomises what you just talked about there, Kathy, the people of Derby and Derbyshire, they're not people for health colleagues, they're not people for adult social care colleagues, they are the people that we all see across our services. From an adult social care point of view, I think supporting people, as many people as we can, to be re-abled at that point of discharge from a hospital is definitely where we want to be. From an adult social care perspective, we don't have enough re-ablement at our front door. So we wait till people have gone through a certain pathway and then see them when they come out of hospital. But our new adult social care strategy is all about how do we support as many people to be as independent for as long as possible and live in their own homes and their own communities. So from our point of view, from a social care point of view, we will try and build on this and look at how we can have rehabilitation opportunities at our front door when people first come to say they have got a level of need.
Christine.
That's it, thank you. I just wanted to ask about the link between this service and Team Up. And I don't know whether there is Team Up in Derby City, the same as there is across the rest of the county. But obviously in Team Up, and the districts, I think, provide a service there in terms of helping with falls recovery. And obviously that's all about keeping people independent. So I just wonder how much this service is linked to Team Up. And I suppose the other thing I would want to stress, because it's a key element for us at the moment, is that the costs of the district councils continuing to support that Team Up approach is becoming really challenging. And I don't really know whether if when we're looking further forward, we see that as being a really critical point, whether there aren't some conversations that we need to be having about that.
So it is intimately linked with Team Up. It is a part of the response that we would have, particularly around step downs, so out of the acute, within Derby City. And Derby City does have a Team Up capability that is, it's led by the primary care networks, but it is a team of, and as Cathy saw, a team of local authority, voluntary community, social enterprise, faith sector, and health coming together to meet that need. And to Andy's point, it's also around trying to intervene before people end up going into an acute hospital environment. So trying to do that upstream work that means that you know, the most expensive place to be attended to is probably in one of our acute hospitals, and it's a place we need to try and keep people away from if at all possible. So it is linked. On the point around the financial pressures in the boroughs, probably not for this meeting, it's something to take out, but effectively it is part of an integrated care strategy.
Any more questions? Comments? No? Right, if we can end the meeting now. Okay, thank you.
So I hope everyone will be able to join